Hello, welcome to HRS TV. My name is Jeanne E. Poole. I am the editor-in-chief of the Heart Rhythm O2 Journal. Today we're bringing you a video from Global Voices. Global Voices is an initiative within the Heart Rhythm O2 Journal where we are interviewing different physicians that work with individuals in developing or underdeveloped countries. We are looking for people to publish papers that reflect the global world and the global delivery of electrophysiology care. Today we have with us Dr. Thomas Crawford from the University of Michigan. He started one of the first programs that brought recycled devices to countries that could not otherwise get pacemakers. I'm also going to introduce to you Uma Srivatsa. She is our section editor for Global Voices of the HRO2 Journal. Uma, I'm going to turn it over to you now.
Thanks, Jeanne. And hi, Tom.
Hi.
How are you doing?
Doing great.
Welcome to HRS TV today.
Thank you.
So we are sitting in this beautiful San Francisco, which is the financial capital, I would say, probably of the West Coast. But here you are talking about pacemaker recycling, which is benefiting a lot of people out there in the world who don't have any other means of obtaining those devices. So let me start off by asking you a quick question on what do you think are the disparities of the CIED devices around the world?
Well, what we know is what's been published by Dr. Mond and by other groups like the European Society of Cardiology and Pan-African Society of Cardiology, which basically reported on the number of devices being implanted each year per million of population. That's a useful comparison. So, for example, in the United States, we implant about 750 devices per million population every year, which ends up to about 250,000 devices annually. You can compare that with Europe, where it ranges from as low as, let's say, 135 or so in Ukraine, and as high as 1,200 pacemakers per million population in the Netherlands. However, when you look at the surveys in Africa, those numbers are in single digits most of the time, and sometimes even fractions. So it's clear that the burden of cardiovascular disease is not that much lower in those countries, and actually 80% of cardiovascular disease actually happens in low and middle income countries. So there clearly is a great disparity in access to pacemakers.
And I would probably venture to say a lot of them are field workers, agricultural workers, and they're in need of a chronotropic competence, would you say?
Well, so actually in my experience, the vast majority of patients that we help have actually complete heart block that they live with for a number of months or years until somebody delivers a device and somebody is able to implant them. So unlike in the United States where it's sick sinus syndrome, it's actually complete heart block, but of course that is a form of chronotropic incompetence. And it certainly affects patients in Latin America with Chagas disease. Heart block and cardiomyopathy are one of the factors, and the patient population lives outside of cities in
small towns.
In small towns and basically are prone to the tick disease.
Sure, yeah. Absolutely. So what got you on this journey? And tell me a little bit about your organization and how does this work?
That's right. So the organization is called My Heart, Your Heart. And actually, I don't take credit for establishing it. So one of our fellows, Dr. Tamir Bauman, and I'm an attending at University of Michigan, he did a procedure on a lady who subsequently died within 2 or 3 months. And so her husband came to our cardiovascular center with the device in a box saying, I was told that this was going to last 12 years. My wife only used it for a couple months. I hope that you can use it. Mm-hmm. And so this band has really initiated this. And so Tamir and Dr. Kim Eagle, who is one of our senior mentors as well, have looked at the published literature until that time. And indeed, we published a meta-analysis in around 2010 or so, which basically showed that prior studies, which were done on all continents, showed that the infection risk, which is usually the main fear that people have, actually was not significantly different. What was different was the the risk of malfunction. And so in that meta-analysis, it was almost like 4 or 5-fold higher risk of malfunction. But pacemakers are extremely reliable devices. So, and also many of these aspects of malfunction could be identified during the implantation. It's usually a problem with a set screw, and so you can actually potentially replace that device if you have a spare one. And so it does not necessarily mean that there was going to be danger to the patient going forward. There was no increase in mortality in patients who received reconditioned devices compared to the controls that were in that meta-analysis.
Right. So to reduce those risks, do you pre-screen them? Like if it's a device that's removed from a patient with a sepsis?
So there are two sources for devices for us. There's the funeral industry, and then there's also devices that can be harvested during procedures on patients who are upgraded to a more complex device, like from a pacemaker to defibrillator, or from a defibrillator to a CRT device. And so what I can say is that the yield from the funeral industry is about 15% in our experience. And of course, the yield from hospitals, it's like 100%. I mean, when we looked at our own generated changeouts, 50% of them were changed for reasons other than
infections or?
No, it was actually 50% of them were for reasons other than
device malfunction or
other than battery. That's right. So among the 50% that actually were done for other reasons, for non-end of device life.
Got it. Okay.
Where the yield among those was 50%.
Okay.
And we've set a threshold of about 4 years of battery life remaining. But most of the devices that we're able to offer to patients actually have more years than that.
So once the patient gets those implants, after 4 years, or when the battery dies, are we able to service them again?
Well, so far we have not had to do that yet, but we are in it for the long haul, and so we will be around, and of course our top priority would be replacing the generators on patients that we've already served, in addition to serving additional ones.
Right, and where is your presence? Which countries are you serving right now?
So we have presence in Sierra Leone, in Kenya, in Nigeria, in Venezuela, and in the Philippines.
Okay. And how did you develop the contacts there?
Every time we publish a paper, somebody approaches me, and it's usually by word of mouth. And really, this is a sort of random alignment of countries. It's because there usually is a person who has a personal connection to that country who is able to contact me, and who also can orchestrate a letter of approval from the local government. That's one of the major requirements of the FDA. So because this is a university project, it is under the auspices of our IRB.
Sure.
And we approached the FDA several years ago to obtain an export permit for those reconditioned devices. And one of the conditions was that we needed to provide government letters from the recipient countries that would acknowledge the fact that they understand that devices are not used in the United States, and that they don't comply with initial specifications.
Right. Well, thank you for bringing up that regulatory piece. So how are these patients monitored?
So in the centers that we use, there are existing physicians that either we trained or they have had the knowledge of how to put devices, and in those patients are followed by the local physicians.
I see. Okay.
Well, I want to just thank you so much for coming today. It's really quite an impressive program that you started with your colleagues. It has a great mission, and it's something that we all need to be able to participate in one way or another in terms of trying to be aware of the needs globally and to try to help serve these populations and our fellow electrophysiologists and physicians working in arrhythmia care. So thank you for spending the time with us today. Uma, thank you for leading the questions.
Sounds good.
Thank you very much.